Esteemed guest and participant, a warm welcome to the closing day of the Taipei Valve Summit 2023. It has been an extraordinary journey of knowledge sharing, innovation, and collaboration over the past 2 days. Let's continue our pursuit of excellence in this field of TAVR. Thank you for your presence and welcome our renowned moderators and participating experts as we proceed to today's first session, Hot Topics in TAVR. Thank you.
Okay, dear colleagues, it is my great pleasure and honor to open this session. I'm Dr. Yin from Chengxin General Hospital, Taipei. This session will be is composed of many hot topics in TAVR. Actually, all the speakers are those who are masters in this field, and they are also our old friends who have been help us in establishing the TAVR program during the past 1 decade. So I think their insight lectures are will be very informative to us. The first speaker will be Eberhard Grube, our old friends from Germany. I think everybody knows him, and he's gonna talk TAVR, present status, and future directions. Grube, please.
Good morning, everyone. My name is Eberhard Grube, University of Bonn in Germany. I want to thank all the organizers to again having me, unfortunately only virtual, but hopefully as months will move on that we will see each other in the future in person. Today's lecture, Life Journey with TAVR, what have we learned after 20 years and what will bring the future? So this is my conflict of interest, disclosure of relevant financial relationships. And I would like to start with our interventional heritage. We believe that less invasive is better. We are technology addicts. We are passionate about experimental and clinical research and evidence-based medicine. We rely heavily on adjunctive imaging and physiology. We are passionate about the interface of clinical medicine and the rapid communication of ideas. We have a vibrant entrepreneurial spirit, and we strongly support and promote global and multidisciplinary collaborations. So let's start with the early confrontations. As we all know, the early days weren't that easy for TAVR. There was a confrontation between the cardiovascular surgeons and the interventional cardiologists, and soon the early skeptics appeared and stated this crazy and senseless project will fail and represents unacceptable and unethical experiments in humans. That was the beginning. On April 16, 2002, 21 years ago, the first TAVR case was done by Alain Crébier in Hwang in France. Most reviewers at that time thought TAVR will never work. It is a stupid and unethical idea, and surgery is good enough for all aortic stenosis patients. The rest is history. Today, TAVR is becoming mainstream therapy, saving lives and improving non-surgical quality of life. TAVR gave birth to structural heart interventions. What have we learned? Most importantly, there was a shift in focus as we moved along with success in the randomized trials. Initially, obviously, we had to focus on procedural success metrics. And as we moved along, now in today's world, managing metrics are in focus. Hemodynamics and PPM, durability, life expectancy, and coronary access, and TAV and TAV considerations. Very important what we have learned. Initially, we started with 2D echo, as we all remember, but the native annulus is overly shaped. 2D measurements, assuming a circular shape, are problematic and was prone to errors. Today, we know that CT and MRT is the way to go in order to measure the annulus and the upper structures above the annulus and below the annulus fundamental. So this is an important step that we did. Also, the axis trends from 2012 to 16 changed. In blue, you can see transfemoral now is the major way to access a patient. Transapical and transaortic basically went down. Also, we were looking into minimalist strategy. The next decade will see an optimization of the TAVR procedure and lower resource utilization, making the procedure more efficient and economical. What were the challenges for TAVR devices when we started? The big five: stroke, PVL, kidney injury, conduction disturbances, and bleeding. We've done well. This is a summary of the STA's national database. Mortality came down, bleeding came down, pacemaker rates came down, and even the stroke rates came down. However, they're hovering in the range of 3 to 1.5%, depending on how intense you are looking at it. How did we achieve those? We improved deployment accuracy, ease of use by new repositionable systems, and by continued advancements with advanced steering, torqueability, depth control, and low-profile materials. Also, we wanted to ensure durability by continued trial follow-up and by engineering and bench testing with tissue engineering, FEA modeling, and animal testing. Today, we have many TAVR choices. How do we optimize outcomes with each, and which device is best for which patient? What then determines the device choice? Summarized on this slide: physician preference, company relationship, ease of use, patient anatomy, and reduction of complications. However, no matter the device, there are two keys to optimizing TAVR outcomes and reducing complications: patient evaluation and sizing, and correct implant technique. Each device has its own nuances for sizing and for implant technique. You must understand the specifics for the device you are choosing. We went on from evolution to revolution. Beautiful, the evolution of clinical evidence is shown on this slide from Stefan Windecker. You can see on the left side, across the risk spectrum from inoperable to low, with two leading devices, TAVR was the same, if not superior, to surgery in all randomized controlled trials. There are three foundational pillars in the modern era of TAVR: the heart team consideration, image-guided therapy, and life journey considerations. So where are we going from here? In today's fast-changing, turbulent world, it is hard to predict the next year, not to speak about the next years. However, the future of medicine, and specifically of structural heart, is not something to predict. It is something to build. This very year, at the 21st anniversary of TAVR, we can look back with pride and astonishment and implement the experience we built to the existing unmet needs, driving innovative therapeutic solutions forward. We expanded indications by bicuspid, small annulus, asymptomatic moderate aortic stenosis, and aortic regurgitation. So let's start with bicuspid aortic valve disease, something that has their geographic differences. In the Asian population, it is very, very common, and we learned a lot over the years. There was a novel classification system, no RAFE, non-calcified RAFE, and calcified RAFE. The approach might be different. One thing is for sure, as we can see on the right side, the more calcium you have, the worse the outcomes, impacting mortality. Additional considerations for bicuspid aortic valves: degree of calcification, as we stated before, the location and length of the RAFE, and sinus of valsalva width and height. Also, all those are important considerations to determine appropriate TAVR size in this disease entity. Open questions remain, particularly, is there a need for randomized controlled trial? Which valve is optimal? And then, of course, the sizing methodology. Moving on to aortic regurgitation. We know with present devices, we do have challenges, both anatomic and procedural challenges, basically because there's no anchoring structure, no calcification, and usually large annuli. The scenario changed with the approval of the first dedicated valve for aortic regurgitation, the Jeng trilogy valve, as shown here on this slide. This valve is approved in Europe for both aortic stenosis and for aortic regurgitation. It does have a unique design to secure and seal the valve in the native anatomy. It aligns with the native cusps, so there's a natural commissure alignment, and the locator clips clip onto the native leaflets, forming a natural seal and stable securement. There's also, obviously, using this technology, depth control. On the right side, large open cells provide access to low coronaries. The ALIGN aortic regurgitation study, Europe and the United States, is finished, completed. We're waiting for the results that will be presented. Meanwhile, I would like to show you the German registry in 95 patients. As a summary, you can see on the right side, excellent elimination of aortic regurgitation, 96% none or trace AR. Technical success very high, device success high, no second valve required, 30-day mortality 1.7, and moderate or severe AR 0. Looking at the lower part, also an interesting situation, the new pacemaker rates. In the aortic stenosis cohort, the pacemaker rate was very, very low, 2.9%. In the aortic regurgitation cohort, it's 18%, but that will change as we move along and we understand better and more how the valve behaves in aortic regurgitation, mainly by sizing changes. Small annulus patients, very important. The answer will be done in the SMART trial, randomizing Medtronic Evolut and Pro Plus to Edward Sapien and Sapien Ultra. Important, not only the primary endpoints, death, disabling stroke, and e-hospitalization heart failure, but also bioprosthetic valve dysfunction, something that's very important in today's world. Obviously, as we move along and consider life journey issues, we must investigate early intervention to avoid myocardial damage and further improve lifetime outcomes for these patients. However, obviously, there's challenges in timing. What is the best time to intervene? It shouldn't be too early, and definitely it shouldn't be too late. Challenges in staging. How should we stage? What are the definitive criteria for staging 0 to 4? And then which means should we take echo, non-invasive or invasive criteria? The next very important topic is obviously durability. Durability is controversial. It is a process that starts with hemodynamic deterioration, moves on to degeneration, and eventually failure. But since these are all bioprosthetic valves, eventually all these valves will fail. Until there's long-term reliable clinical and echo data on normal risk patients, there will always be concerns regarding durability. However, THVs have collected more rigorous durability data today than any surgical valve. And this is the good news: severe SVD 1.3% and bioprosthetic valve failure, BVF 3.7%. Good news, and we hope that these data will continue. In order to address durability, alternative materials are actively being researched, and this research may actually address shortcomings of current bioprosthetic valves. The promise, one valve for life. Maybe at some day we will have this valve for life. Next generation heart valves moves on, particularly addressing durability issues by technology changes of the leaflets and the materials being used. Anterior's Dura THV, Edwards Resilia tissue valve, and the Foldex Trier TAVR with polymer leaflets and robotic manufacturing. Interesting, the Valve Medical ultra-low profile TAVR system, the Gemini valve and system design generation 1 and 2 are shown here. The modular system, which addresses particularly access issues, also changes in material at the left lower 3D piece in order to address durability issues. And this is a comparison of the Geminis delivery catheter, 4 mm and 9 French, comparing it to Evolut and to Actuate Sapien. The first successful 12 French OD was done in Dante Pasanese, and last week with with our Israeli colleagues, also Eric Finkelstein was there, and Rand Kronowski, the first successful implant of the 12 French was done with the next generation devices. Key concerns for failed THVs and coronary access should also be discussed. How do we plan future re-interventions? Should we start the surgery? Should we start with TAVR, or should we use TAVR altogether? Whatever we plan, whatever we decide in younger patients, the goal is to minimize open heart procedures and avoid performing them when patients are older and at higher risk for surgery. If we have to do TAF and SAF or TAF and TAF, we can use less invasive approaches for those failed bioprosthesis. Important main concerns are PPM, patient prosthesis mismatch, coronary obstruction, and thrombosis. All those have to be addressed when we make decisions which procedure we should be starting with. Approach to coronary heart disease in patients undergoing TAVR, many are being used. How do we choose a strategy? Obviously, it depends on patient symptoms, lesion complexity, comorbidities, and the coronary access post-TAVR. Whatever we decide, anatomic and device features in today's world should allow and guarantee coronary access. It is fundamentally important that the devices are constructed and positioned in order to allow this. Then also, commissure alignment, a must today. We have learned a lot stent, post, and commissural alignment between the native aortic valve and transcatheter valve is a procedure modification that may also help to ease future coronary access. Finally, a disease state continuum of care will emerge. Longer-term management of TAVR patients will improve with the ability to monitor patients from home with minimal disruption to their daily lives. This technology, along with improved home care pathways, will allow a greater number of patients to discharge to home. Finally, what can we learn from the TAVR success to future trends in structural heart disease? Interventional cardiology has been driven by technology innovations and by better understanding the cardiovascular diseases. It is the individuals with strong conviction, vision, risk-taking, and resilience, teaming with technology innovators who have been driving forward new therapies and challenging the IC community with out-of-the-box ideas. With that, dear friends and colleagues, I would like to finish. I thank you very much for being part of this meeting. Thank you, and be safe.
Thank you, Dr. Grube, for your excellent talk. Okay, this is a didactic course, so I think the next speaker, I would like to ask Dr. Cao to introduce the second speaker.
Thank you, Professor Yin. And the speaker is Professor Arik Finkelstein. Professor Finkelstein is a professor, director of cardiac catheterization and intervention at Tel Aviv Medical Center, Israel. And Professor Finkelstein is a good friend of us and has always supported us. And today he will address a very important topic, the management of TAVR complications. Professor Finkelstein, please.
Good morning, everybody. Thank you again for having me in this wonderful meeting. You know, yesterday you gave me 15 minutes in order to give an overview of all TAVR. And today you gave me 15 minutes to talk about the management of all TAVR complications. I don't know why you're doing this to me, but anyhow, I decided to try and make the solution of a complication that is common to all complications we have in TAVR. And that was quite a task. So when I came to build this so-called lecture or talk, I said, well, I have so many complications that I had experienced in my TAVR career. Well, shall I show how to prevent this annular rupture? Or maybe, shall I talk about how to prevent this aortic dissection? It's all my complication, by the way, all right? Shall I talk about prevention of this devastating iliac rupture? Or maybe this coronary obstruction? Or this careless rupture of the descending aorta? Or this valve that just went for a walk in the aorta? Well, the winner is, no, as I said, I decided to take one that the solution for it is common to all complications. So I've chosen a complication, the management of which is common to almost all TAVR complication one may experience. So I'm going to tell you about this nice old lady. She's 85 and she's 10 years after TAVR procedure that I was doing in Tel Aviv Medical Center. It was the first generation of the core valve. And now she came with a dyspnea and she have severe valvular regurgitation. This is just failure of the valve. And this is the way it looks like. So we wonder whether to do a TAVR in TAVR or to send her for another surgery. And I'm showing you a case that was like 2 or 3 years ago, before what we learned about VTC, VTA, etc. So this paper of Winnie Buffett shows us today that the mortality in the explant is truly high, and it's much higher than in redo TAVR, according to this paper came on. And as a matter of fact, we have done this before. We had cases of TAVR in TAVR even before that. We did this before Edwards in the failed core valve, and we had a core valve in the failed Edwards. So we went to this lady, and we did a CT, and the left main was high, and the right coronary was high. So we decided to do a valve in valve, a TAVR in TAVR, with an Edwards in. So just in order to make sure, we did coronary protection to the left coronary, because the left coronary was big, the right was small. We put the valve here, we implanted it, and, oops, sorry. And this is the final result. It looks nice, there is no AI, oops, I'm sorry. And even injection here shows that there is left and right coronary fulfilling with dye, and everybody was happy. However, 3 days later, the patient complained of chest pain. She had ST elevation, echocardiograph showed akinetic inferior wall, and within minutes, she just collapsed and died, all right? And that was my job. Now, I'm gonna skip many slides because there were so beautiful lectures yesterday about the coronaries and TAVR and TAVR. But you know, we've learned a lot from this important paper in 2020 about the coronary access and the coronary protection and the risk for coronary obstruction during TAVR and TAVR, in which the VTA and the VTC should be measured. And when is it more important and when is it more dangerous? So I'm going to skip it. And then we had this huge registry of Uri Landes that used to be fellow of ours, and the dangers of which valve in which valve you have when you are doing TAVR in TAVR. And the nose skirt, a term that we did not know before, and definitely we did not know when he did this case. So I'm going to skip all those. And just let's go back to our patient, all right? This nice 85-year-old lady. And if we go back to our CT, we see that, yes, the left main is high, the right coronary is high, but there are two more important things. The VTC here to the left is 3.3 millimeters, and the VTC to the right is even less than 1 millimeter. And the VTA is almost zero in both of them. So we were taking care of the left coronary. As a matter of fact, we should have taken care more of the right coronary. Now have a look. You see, this is injection, but I don't remember if it was here yesterday or in Korea that one gave an injection and said, this is too early. You should look at it later on. So 3 weeks later, we had another patient, a 70 years old with 9 years after TAVI, etc., etc. And this time we had a look. So the coronaries were high. The VTA was 2.5 here and put 2.5 here. And as we say in English, once bitten, twice shy. In Hebrew, we say different. Got burned by hot water, you now beware of cold ones. So this is the man, and this is his AI. So we put a guiding catheter and a wire on the right coronary. But mainly, I'll go and skip it on, what we did now is what we heard yesterday so many times. We implanted the valve much lower with the overhang. So this left us with maybe a bit smaller orifice area, but with a much less chance, of Whoops, it doesn't work. I don't know, but with a much better coronary protection. And this is exactly the overhang that we choose to do. I'll skip on that, and I'll skip on that because they are all slides that you have seen yesterday. But I'm trying to show you all this, and I said that this is a complication, the management of which is common to all complication. It's not the management, and it's how do you manage coronary complication, TAVR complication, but mainly how do you prevent TAVR complication. And the best way to prevent TAVR complication is by CT angio and imaging, pre-procedural imaging, which we did not know so far to do perfectly. And now, only now, we're learning it more and more. And this special imaging is going to show us in the future how it's going to be the TAVR in TAVR before we are implanting the index procedure. And it's going to help us implanting this and planning everything like this beautiful paper of Whitaker. And in other words, the huge importance of CT angio before TAVR procedure cannot be overemphasized, because all these we're learning, and this helps us to predict and prevent complications in TAVR. So in summary, Mr. Chairman, ladies and gentlemen, there are still some serious complications during and after TAVR. Coronary obstruction during and after TAVR in TAVR is only one of them and is associated with very high mortality rate. Low left main, shallow sinus of Valsalva, and VTA less than 2 millimeter contribute to higher risk of coronary obstruction. Prevention and treatment for high-risk patient during the procedure is best utilized by preemptive coronary protection or other techniques, as we know. However, as our experience in TAVR procedure expands, as we have experienced most of them, the best way to treat TAVR complication is to prevent them. Prevention is best utilized using a meticulous pre-procedural imaging and measurements. Oh, it doesn't work. Thank you so much for your attention.
Thank you, Eric. Very great talk. So any questions or comments from our audience or panel?
Since you probably the only the live talk, so I give a comments. The next few, I think, was recorded. So I think that you give an excellent talk. I think it's very important that to share the bad things and not the good things, because we always hear the excellent, everything's perfect and no complications. I think everybody do more TAVR definitely have experience. I have all the experience. I can share you 10 experience, but more than you. So I think everybody, if you do more, there's experience, complications. So I think it's the questions right now is like yesterday case or the same, like for which point we say we shouldn't do it. Because sometimes nowadays we always push for the TAVR, and even with a very high risk, for coronary, for ruptured, and then we still push for the TAVR. And this, I think, that's most difficult part to say no nowadays. What your comments for that?
Thank you for the question. I think it's a very important one, since this is more kind of a philosophical question, and it touches our career from the beginning. Where is our professional dignity? Where is our professional honesty? And where is our professional wisdom beyond medicine? And this is beyond medicine. And the cost effectiveness of a procedure should always be the cost effectiveness of the procedure to the patient, not to you. And, as I said yesterday, we are a little bit too hungry to do procedures from the beginning. And I think that part of your being a mature interventionalist or a physician in general is the moment that you don't think of yourself and of your career anymore, but rather more of what is good for the patient. And you know, I can go on and on, but you know, each one of us remembers from his career that when he was a young physician and he did a mistake and something happened, the first instinct used to be, what is my boss going to tell me, or what am I going to get for that? Let's be honest. And there is a turning point in your career that you don't think this anymore. You think, oh my God, what have I done to the patient? And nothing else. And I think that this is part of our job. And this is part of our dignity and part of the reason that we're doing this profession. So I'm sorry that I went into philosophy, but your question is more philosophical.
Thank you. I just, you know, I think that this is a very important, you know, message, you know, put in the audience. I think, especially there's now so many centers and then so many young, you know, operators there. So like you say, they're trying to do everything. So another thing is, I think for the left main occlusion, I found it's very difficult to assess delayed corneal obstruction. That's the one thing that I feel is very challenging, because I also had one, and the initial was perfect, and then later on the band. That's the most risk complication, because most patients died. We discharged very early, and then they usually home, or even like they just.
This is a very, you touched a very important point, because, and people doesn't realize that. Now, the last slide that did not work is a soccer game in which there is a pendle. You say pendle in, you know, yeah. So he's shooting the ball, and the guard thinks that he stopped it, and then the ball is going back and goes into the net. And it shows that it's not over until it's not over. And you know, when I was young and I went to my first private visit, I was so proud. And then my father said to me, "Hey, Eric, just don't count the money in the stairs, because you may fall down. So you don't count the money in the stairs in TAVR, and it's not over until it's not over. And even if you finish the case and it looks wonderful, coronary obstruction can happen an hour later, 2 hours later, and even 2 days later, because it's expanding, it's building a nidus there, which grows, etc., etc. And you cannot finish a procedure in which the left main is just hang on a tight stenosis, which you don't appreciate now, but you will appreciate it in the next hours or days. So this is very important, what you asked. Don't count the money in the stairs.
I have a question for you. If the patient are going to do the TAVR in TAVR, but the patient has a very narrow ST junction, or expected a high neo skirt, would you do the TAVR in these patients, or you do some what kind of management or assessment about this patient?
I think that we are going into an era that should have started a long time before, but we're going into an era that touches almost all the lectures that were here of what we call patient-tailored therapy. There is no one treatment to all patients. Now, look, there is no secret that valves that were done lower, namely annular, with a shorter skirt, are having those days a huge advantage. And you know, I'm a great fan of Evolute. Okay, I was proctoring for core valves in the very first days, and it made my career, because Edwards doesn't need proctoring. It's very easy to implant. But a core valve, you needed to be a good operator. And I think that they are waking up those days to kind of a nightmare that nobody of us really appreciated before that this supraannular that we saw many years as an advantage for many patients, namely the younger ones, that their life expectancy advocates a very, very high chance of a need for TAVR in the future, for instance, or those with coronary artery disease, that there is a very good chance that they will have to be recatheterized again and again to the coronaries. This is a disadvantage. But again, this is patient-tailored therapy, because for an old lady without coronary artery disease, I definitely think that core valve is my valve of choice. But for a young patient, with or without coronary artery disease, this is not the valve of choice, and they are moving forward in order to create something that will advocate those. So patient-tailored therapy, this is the word.
Any other questions? No, thank you very much, Eric. Very good talk. Yeah. So, Professor, yeah. Okay.
The next speaker will Professor Tang, and I think it's a recorded or it's online. And Professor Tang actually is a cardiac surgeon, but he performed lots of structural valve procedure, including a TAVI and mitral clipper. He performed over 1,000 cases. That's a lot of cases, and particularly he developed a technique to have a better commercial alignment implantation. So this technique has been adopted by the many operators worldwide. So I think he's recorded. Okay, go ahead.
Hello, today my presentation is on lifetime management of aortic valve disease. Here are my disclosures. Right now in the United States, the TAVR volume has exceeded all the surgical aortic valve replacement volume already. And you can see that the native TAVR volume is continuing to climb in the United States. But at the same time, TAV in SAV and TAV in TAV, meaning TAVR in TAVR, is also steadily increasing. The median age of patients undergoing TAVR now in low-risk patients is now getting younger, at around 75 years old a couple of years ago. And you can see that in the AACC AHA guidelines, that age 65 or older patient can be eligible for TAVR, while in Europe is 75 or older. At the same time, TAVR is not indicated in all surgical risk categories. And then, of course, there are a number of new generation valves that are being used. You can see on the left side, balloon expandable with SAPIEN 3 Ultra and soon SAPIEN X4. And the self-expanding valves are just the Evolut FX, Accurate Neo 2, and Navitor. However, durability of any valve prosthesis really depends on patient's life expectancy. You can see here that if your patient's age 65, you expect it to live 20 years. 70, 15 years. If you're in the late 70s, 10 years, and only in your 80s that you expect about 5 years or less. So how do we plan to get someone to live to the mid-80s after a valve replacement? And you can see that this European journal review, assuming that SAVR will last 10 to 15 years and TAVR in 10 years, really there's a number of sequencing that are possible as the patients who are younger getting SAVR or TAVR. And of course, that these patients will be expected to require at least one valve intervention in their lifetime. At the same time, coronary artery disease is not regressing. In fact, over 60% of patients who are intermediate surgical risk in the trials have coronary disease that will likely require revascularization later. So coronary access after TAVR can be challenging because most interventional cardiologists are not familiar with TAVR, and also the aortic root anatomy is variable. And also there are barriers facing the aortic valve in the coronary orifice, such as native valve leaflets, stent frame, and transcatheter valve commissure because of misalignment. Here are two examples of why coronary access can be difficult. You can see on the left side, there's a bulky left main facing the coronary artery. On the right side, you have a low left main from a surgical valve replacement, and now you have a TAV and SAV, so it's much harder to go through all those materials to get to the left main. This JACC paper published by our group a number of years ago now, looking at anatomical and device and procedural factors impacting coronary access after TAVR. And you can see that here there's an app available for free on the Apple or Android platform as well as the website. You can see here teaching cardiologists how to access the coronary with balloon expandable and self-expanding valve with or without commissural alignment. And commissural alignment is important now in TAVR because not just for total valves in terms of coronary access, but also with TAVR SAF in terms of reducing the risk of coronary obstruction. You can improve the likelihood of redo TAVR by reducing the risk of sinus sequestration and coronary obstruction. There's now some evidence of commissural alignment improving halt and in terms of also impacting on gradient. And finally, leaflet modification such as basilica or shortcut is not really feasible if your commissural post in the way. And you can see this JACC intervention review that published by our group showing some of the potential impact of commissural alignment, not just on coronary flow and access, but also paravalvular leak and also leaflet stress. So really important to understand the anatomic relationship in terms of both the aortic root, but also the TAVR device. If you have shorter frame valve in terms of mechanically or expandable, it's going to be more relevant in redo TAVR, but taller frame valve certainly impacts coronary access and redo TAVR. And you can see that here, this is a factor considering determining coronary access and redo TAVR, and you can see that commissural alignment is important in both. So what is commissural alignment? You can see that here, this is favorable alignment on the left side where the transcatheter valve commissure aligns with the native commissure. So you have a lot of space across the cells to engage the coronary versus the right side where it's completely misaligned where the commissural pole faces one of the coronary. And you can see that with the commissural post in the transcatheter being larger and like triangular in shape is to increase the barrier to access if you faces one of the coronary orifice. Suboptimal alignment on the left side shows that if you have coronary arteries in the red dots, you need to go through the cells on either side of the commissural post to engage the coronary. Versus if it's optimal alignment, you can see that you can just go directly above, even if the valve is implanted high. And in fact, you can see that this post-CT study from JACC intervention showed that 11 to 22% of the time, there's a commissural post facing one of the coronary arteries, making access more difficult. And if you have commissural misalignment, you can see that here on the right side, the surgical valve leaflets was split. However, the commissural post can still face that split portion, causing coronary obstruction. This aligned TAVR paper we published a number of years ago now intentionally aligned some of the valves here, and this is a SAPIEN 3 valve. Despite crimping the valve in different orientation, we were not able to achieve consistent alignment. However, with the SAPIEN X4 platform, you can actually see the letter C during fluoroscopy with the valve is positioned above the annulus, and you can rotate the catheter with the valve itself to the proper orientation to improve commissural alignment. So this is currently a step forward. With the self-expanding evolute valve, you put the flush port at 3 o'clock, and you, at the cusp overlap view, have the head marker facing you directly to achieve commissural alignment. And this is more so with the evolute FX. And you can see that if you do that, it does improve coronary access both selectively and non-selectively. Now, the evolute FX platform now can improve the commissural alignment. You can see now over 96% with similar degree of control and better symmetric implants. So I think this is currently an improvement over its predecessors. At the same time, you can see other self-expanding valves, such as the Accurate Neo and Portico, can also be performed with commissural alignment using the cusp overlap view. And you can see that this is a review paper that we summarize all the findings, and I encourage you to read that at your own leisure. Now, in terms of redo TAVR, thankfully, the incidence is still quite low, less about 0.5%, with very good outcomes in terms of mortality and stroke and pacemaker rate. And you can see that this redo TAVR registry also show very low incidence with acceptable gradient and low coronary obstruction or mortality. However, it really depends on the definitions of bioprosthetic valve dysfunction as defined currently by the VOC 3 publication. And you can see that if you have bioprosthetic valve dysfunction, structural valve deterioration currently is amenable to redo TAVR. If it's non-structural valve deterioration with severe PPM, you may need to actually do surgery instead. And the redo TAVR feasibility really depends on a number of factors, including sinotubular junction width, leaflet height, and implant depth. And you can see that here, because of the neo skirt created by the transcatheter valve leaflets can seal off the root. That's what makes redo TAVR unfeasible. And you can see that with this balloon expandable valve angiographic study from our group, that at least around 20% of cases may not be feasible for redo TAVR. However, you can do a commissural alignment. You may be able to modify the leaflet of the transcatheter valve to reduce the new skirt height. You can see that here, and potentially improve the feasibility of redo TAVR. Certainly with commissural alignment, it's also important to orient the transcatheter valve, either the first or second valve, depending on the height of the valve, to improve coronary access so that you don't have a barrier in the way facing the coronary after the second valve is placed. And this is important. You can see that this JACC intervention review published by us, also looking at commissural alignment being one of the key features. Other additional factors looked at the redo TAVR for lifetime management, including the neo skirt height, as I mentioned, implant depth of the first valve. In terms of expanding the THV, do you need to expand the first valve first to optimize the landing zone for the second one? What about the issue of leaflet overhang, where the second valve, the leaflets actually hang over the first, under the first valve, and so may make the second valve function compromised. And finally, the second valve may deflect the leaflet outward of the first valve, maybe potentially increase the risk of coronary obstruction. I have a YouTube video channel of some of the videos showing how to do redo TAVR. You can read it and watch it at your own leisure. I think it's important to look at the CT evaluation. However, fluoroscopy is also important. You can see that's the 3 different SAPIEN cases. Some of the cases look a bit more ominous, but actually turn out to be more favorable. However, it can go the opposite way, where it looks favorable, but on angiography, it looks ominous. So you have to do both to confirm the feasibility. Sizing is also currently unknown. This is a proposed sizing algorithm, but certainly it needs to be validated. And of course, there are other factors impacting redo TAVR versus TAVR explant, as shown in our paper here. Certainly lower surgical risk patient, especially with PPM, and risk of coronary obstruction may be favorable for explant rather than redo TAVR. And TAVR explant is a problem because it's not like the first time of redo TAVR. With TAVR, you take out the native leaflets, you debulk the calcium, there's clean tissue plane to implant a surgical valve. And so if you want to take it out, it's easier than you should take out a TAVR valve because it doesn't impact on the LVOT, mitral valve, or ascending aorta. Because these things can be stuck to the native aortic valve leaflets, to the transcatheter valve, so harder to explant. And it's not just the native leaflet. Remember, there's other adjacent structure. So if you cannot debride the tissue and remove the device, especially when the device has been implanted for a longer time, you can risk other cardiac injury. So you need more extensive surgery and repair. And with the taller valve, you can extend the ascending aorta. So you need to have a higher aortotomy, higher cannulation site, cross-clamping site, making the procedure of surgery more difficult. And of course, if you implant the valve deep, you can impinge on the septum. You can cause a VSD. You can injure the mitral valve, so it's no longer an isolated AVR. And these are some of the pictures that are removed. So in pictures valve that are removed, you can see that it can impact on the aortic root, membranous septum, aorta, and anterior mitral leaflet. All can be injured with TAVR explant. And you can see that it is a potentially risky operation with a 1-year mortality of TAVR explant approaching 30%. With the redo TAVR, certainly is safer. And this paper just came out in JACC intervention comparing between the two. However, you can see that the patient with PPM more likely to need TAVR explant because redo TAVR would not be feasible to avoid that. And of course, this is our first initial paper showing the same thing with mortality and stroke very high with TAVR explant. So surgeons need to do a better job in explanting these valves and develop standardized techniques. If you need to bail out the patient and you need surgery, you can certainly remove the transcatheter valve leaflets and then directly implant a TAVR valve to avoid coronary obstruction. So in summary, TAVR is indicated all surgical risk patients with aortic stenosis, but lifetime management strategy is key. High-risk anatomy patients who are low surgical risk and even intermediate risk should consider TAVR as alternative, especially if redo TAVR is not feasible. Coronary access and redo TAVR feasibility are top issues in lifetime management now after index TAVR, and we cannot emphasize more that commissural alignment really is important now to facilitate both coronary access and redo TAVR after index TAVR. Reduced TAVR feasibility, as you see, depends on multiple factors, especially anatomy, and we need to learn new vocabularies and the unknowns that we need to further investigate. TAVR explant is a more complex operation than first time or reduced TAVR, and better techniques are needed to develop to improve the outcomes. And a thorough multidisciplinary heart team, I think, discussion is important in young patients undergoing first-time aortic valve intervention. So the optimal strategy to enable lifetime management of both bioprosthetic valve dysfunction and CAD can be accomplished. I'd like to thank you very much for your attention.
Thanks for the excellent talk, Dr. Tang. I guess this is recorded. So I think Dr. Bapat will be joined later. So we probably move him to the last speaker. So we'll move on to next speaker, Professor Petronic. She is online, or she has a recorded.
Good morning to everybody. I'm very pleased to be here with you, but online and not with you really. I would like to talk about the problems of sizing, and in particular the algorithm that we have thought on the sizing of bicuspid valves. Now, these are my potential conflicts. Here are reassumed all the kinds of measurements and morphology of the bicuspid valves. You can see here the classic Sievert's classification, and then the other ones that has been done according on the studies that in the last years have been done on the possibility of performing a TAVR in bicuspid valves. Now, of course, the bicuspid are challenging anatomies. They are various, and they have a challenger to be treated by TAVR valves. The incidence of BAV are increasing because the indication of TAVR it's been enlarged and expanded. So now that we are also considering younger patients, we have to think if it is right to perform a BAV with a TAVR nowadays in a younger patient, and when it is possible, and it is important to understand how we size, which is really a debate still, and it's not very clear. The anatomy of the BAV has, let's say, different plans, because if you consider the annulus and you consider the sinus of Valsalva through over the aortic root, it was possible to find different shapes and different relations to the annulus. We can have, like in the Bapat multicentric registry, we can have a tubular aspect. This means that any part of the in the aortic root, it has the same dimensions that we measure at the annulus. Or we can have a flare type, or we can have a tapered type, which is more, let's say, common to find, especially in calcified type 1 BAV. Now, recently, it has been pointed out the importance of the amount of calcium on these valves and the presence or not of a raphe, and the importance and the distribution of the calcium on the raphe. Here in this paper by Yung in 2020, we can see that these kinds of patients, the ones that have a calcified raphe and an extreme amount of calcium anyway, with or without the calcium, have an outcome which is different from the other patients. You can see that there is a difference in outcome in all cause of mortality when the calcified raphe is not there, when there is not an extreme amount of calcium, or when both are present in the valve. You can see that there is a significant difference in patients that have the raphe or don't have the raphe, and there is even a higher significance in difference when these raphe are calcified or there is an extreme calcification of the leaflets. These anatomies are very important when you think about the sizing, and there are many different kinds of sizing that have been thought for the BAV. Well, I think that we could talk about an annulus method and a supra-annulus method, and you will see that the CASPER algorithm that we have constructed, it is something in between. It is not really neither supra or annular. The difference that has been found by measuring the annular method or the supra-annular sizing in this paper has been evaluated that the annular sizing has generally, with a 96% of times, an appropriate sizing for the valve, with very little oversizing and very little undersizing, while the authors say that there is a diversion sizing selection when you measure it at the supra-annular part. When we talk about balloon expandable valve, it has been written a consensus that the circular method, it is something that helps to define annulars that are smaller in respect of the supraannular planes or are tapered. Now, what will you do with the circular method? You just can calculate and evaluate where the circle finds and touches the border of the root in different planes, scrolling the plane up and down. And this sizing has been thought to be nice for a balloon expandable valve. There are other sizing. This was made in China, which is a balloon sizing that measured the shape of the balloon while it is trying to find the smallest diameter that is possible in that valve. The lever method is one, together with our algorithm, that considers the raphe and the calcification. But this method looks exactly the perimeter that is designed on the plane where you can see the raphe. And this, it creates a supraannular measurement. So we could say that the Lura method is a supraannular sizing. We have suggested something different. We have considered always the annular sizing. We look at the annulus, we scroll up the plane, and we visualized and measure the calcium score in millicubes and the length of the raphe. We see if the calcium score is over 300 millicubes, and we see if the raphe length at the height of the raphe, it is more, longer or shorter than the 50% of the derived diameter with perimeter or area calculation. If one of these, it is, if the calcium score is higher, we detract 1 millimeter from the derived diameter at the annulus. And the same we do with the raphe. So at the end, we can find a diameter which is exactly the same of the annulus, or it can be diminished of 1 millimeter or 2 millimeters, or 2.5 millimeters if the raphe is calcified and it's long. We have tested this algorithm, and we make the validation with a group of 21 patients, all treated with a self-expanding valve. Now we are performing a multi-center registry with 110 patients, just to see if all the centers are able to apply this algorithm. Why we sought this? Because we observed, well, with the CTs post-TAVI, we could see that the raphe shortening had an inverse relation with the calcium score, and the expansion of the valve was related with the amount of calcium and with the potential of shortening of the raphe. If we look all the type of measurement that are possible today, this is the CASPER, and we think that this algorithm is able to be applied to many type of valves. It is related to a measurement that everybody is able to do, which is the annulus plane. It's able to evaluate the raphe and once the calcification, the quantification of the calcium. It gives you a number of derived diameter that is always derived by the annulus. This is example of this method. We have here an annulus measurement of 30.7, which is out of range for even a self-expanding valve, or I would say it is really borderline if you would size a balloon valve. And here are applied different methods as the Bavard with the intercommissural measurement, with the supraannular measurement of the intercommissural diameter. And here it is the Lyra plane, which has the measured at the raphe level, but it gives you a perimeter that is drawn by the operator in respect to its expertise. With the CASPER, we look the annulus, we look the derived diameter, we look the amount of calcium, and in this case, we see that the calcium volume is high, so we detract 1 millimeter, which comes from 30.7 to 29.7. But this time, the length of the raphe, even if it's calcified, is short. It's shorter than the 50% of the derived diameter. So we don't consider the importance of the raphe, but we consider the importance of the calcification. So we stick to 29.7. This measurement, it is similar to some others, but some others are more, give you a diameter, which is a dimension which is higher. So in conclusion, I would say that the TAVI in bicuspid valve, it is feasible. Literature has shown you that there is a safety and there are better results with the last generation of the valve. We have potentially good results, but we have to achieve an optimal result with all the patients, especially if they are young. Sizing needs a consensus. We are going on trying our algorithm, and we think that it is a good system to don't find measurements that are separated from the ones that we are usually able to do. But the pre-procedural dimension and measurements are really mandatory, and they need really a good expertise and definition. Thank you again for the attention.
Thanks, Professor Petronic, for the excellent talk on her method in terms of how to measure the bicuspid valve. I think we have so many methods now, so I don't know which one is the best for determining the bicuspid aneurysm. I think everybody has a different, I guess, ideas. Looks like this one is more like a combination and a different method. So I think because of time, I think I will like have Professor Lee to introduce our next speaker.
The next speaker is Dr. Kiyuk Chang. He is president of the Cardiac Cerebral Vascular Institute in St. Mary Hospital, Seoul. And he was very famous cardiac interventionist in Seoul, and is all friend from this meeting. And praise that Dr. Chang, he will give our talk about tips and tricks of aortic valve in valve.
Thank you, Chairman. I'd like to focus on bioprosthetic valve fracture and basilica for intervention of aortic valve in valve. This slide shows the mortality after valve in valve TAVR in the period of no valve fracture. When the patient had a smaller initial surgical valve, their mortality are significantly high after valve in valve TAVR. So small valve size was usually defined as 21 millimeter. Just after valve in valve TAVR, compared with post valve in valve TAVR, the valve fracture improved hemodynamics, so markedly decreased the mean transaortic pressure gradient and increase effective orifice area. So this is because of TAVI valve optimization. Before a valve fracture, after deployment evolved are 23 meter in an intact Magna 21 millimeter surgical valve. As you can see in this slide, the alignment, the deplete alignment is poor, the valve deplete is distorted, and valve expanded to only 19 millimeter. But after valve fracture, the deplete alignment is optimal, and valve expand to 22.9 millimeter. Thus, for optimal TAVI, in cases anticipating patient prosthetic mismatch, especially patient having surgical valve size less than 21 millimeter, valve fracture should be done at the time of TAVI implantation. Luckily, most surgical valves can be fractured except the central trip effect and Mediterranean Hancock. So we have to use non-compliant balloons for valve fracture, and worldwide the two balloons, True and Atlas Gold, are available. In Korea, only Atlas Gold is available. So when you're doing a valve fracture, you should the balloon size should be 1 millimeter more than surgical valve size, and 3 millimeter more of internal diameter of surgical valve deplete. So you have to increase inflate the non-compliant balloon up to burst pressure. In case of 20 or 22, the balloon increase a little bit 1 millimeter above. So this is the initial setup for high pressure balloon. So you need a large syringe, indiflator, high pressure stopcock. So at the time of balloon inflation, initially you have to rapidly inflate the syringe to inflate the balloon, and then turn toward the stopcock So the interpreter, the increased pressure, and then certain degree. This is the usual setup for high pressure balloon at the time of valve fracture. In case of the evolute implantation at the time of valve fracture, you have to remind of a constraint area. So in case of a 23-meter evolute R implantation, the constraint area diameter is 20. So maximal recommended balloon size should be less than 22 millimeter. Another consideration, so when using high pressure balloon rather than constrained area of self-expandable TAVR valve, keeping the shoulder of the high pressure balloon below the constraint area, it prevent the risk of tearing the leaflet. So it's all questions. When is better to do valve fracture during TAVR procedure? So listen the 2023 JEC intervention paper, the reported the TAVR first and then valve fracture, optimized expansion of TAVR prosthesis better than valve fracture first. So it need to better 1 year clinical outcome. So now our center also do TAVR first and then valve fracture at the time of valve in valve TAVR. However, valve fracture increase the chance of coronary occlusion. So originally the chimney stenting was used to prevent coronary occlusion, and soon later basilica was developed. When you compare these two techniques for the prevention of coronary occlusion, basilica looks more physiologic. So at Europecia 2023, the Italian group reported 1 year event rate between basilica and chimney stenting using registry data. The included patient was 168, their age 80-year-old. So 1 year cardiovascular mortality, basilica 1.3%, and the chimney stenting 6.7, but number is small, the statistically insignificant. All cause mortality also basilica group showed no mortality. The most important limitation of chimney stenting is future re-engagement of coronary artery is extremely difficult. And another concern is stent distortion and risk of restenosis and risk of stent thrombosis. I like to show our case. The patient was 82-year-old female. She arrived emergency room because of severe shortness of breath. In her past history, pacemaker was implanted in 1993, and later permanent AFib and subsequent renal infarction in 2018, and surgical aortic valve replacement using MitraFlow 90 millimeter was implanted in early 2019. She has also stage 4 chronic kidney disease, and NT-proBNP at ER showed remarkably high. And chest X-ray shows marked cardiomegaly, both perfusion and pulmonary edema. And EK shows all pacing rhythms. And echo shows the increased strength aortic peak velocity 4.2 meter per sec, and BMPG reaches 42, and mild pulmonary hypertension. So her SD score is so high, all surgeons agreed TAVR, valve in valve. We analyzed the valve CT. Her internal perimeter was only 53.3, the perimeter-derived diameter is 17. When considering the degenerate surgical valve leaflet, or actual true internal diameter only the 15 to 16 millimeter. And unluckily, she has smaller sinus valsalva width, less than 28, and then the SDJ junction diameter is 31, relatively wide. However, she has a very low left coronary height, only 6.5. Right coronary height is 11.3. So his main problem is low coronary height and narrowed sinus valsalva diameter, and the height of mitral flow 19 millimeter by prostate was 11. So in her case, her left coronary height is 6.5, and then the height of surgical valve is 11. So the chance of coronary occlusion is nearly 100%. So we planned Basilica before TAVI, and then for the prevention of embolism during Basilica and valve fracture, the central device should be needed, and then self-expand valve implantation, and then finally valve fracture. So before Basilica, we placed sentinel, and then filter was located in the right brachiocephalic and left internal, left common carotid artery. And then for Basilica, first step is set up for a snare system. The multi-purpose guiding catheter is placed through aortic valve and located in LVOT. And through MP catheter, the V18 anchor wire is delivered to LV apex. The rollable anchor wire is maintain stability of snaring system. Yeah, and then usually the single loop 20 millimeter gooseneck snare is advanced through MP catheter and put in LVOT below, just below the aortic valve annulus. And then second step is set up for traversal system. This is most important part of Basilica. And we used the catheter system, first guiding catheter, and next diagnostic catheter, and micro catheter, and finally isostato 20 gram. Considering patient anatomical characteristics, you can choose various guiding catheter, and for the optimal penetration angle, you can choose one of various diagnostic catheter, the internal mammary or MPA or JR. And then only fine cross should be used for the micro catheter to deliver isostato 20 gram. So when deployed traversal, this isostato guide external outer end of isostato wire should be connected to the BOVI system by delivering 50 watts. The leaflet is penetrating by electrofiable guide wire. So this is the setup of our the Basilica system, snaring and travel system, just like this. We used Davis catheter. This is very tricky part. First, we used short tip Emprach 1.0, and then initially the JR catheter and multi-purpose, but failed to achieve optimal the penetration angle. So we adopted Davis catheter. And then the successful penetration of electrofiable wire, and then snare captured and externalized through MP catheter to the outside. before basilica, we peeled coating at the middle part of acetate wire and then bent like this. And V-shaped portion of traversal wire is delivered to the point of leaflet laceration. Yeah, by applying 80-watt electric current to the outer end of the acetate wire, and then the leaflet is split from bottom to tip by putting the electrified wire on both outer end. But you need very strong forces. After then, Evolut core valve 23 meter was smoothly deployed, and then we used Atlas Gold, the 20 millimeter high pressure balloon to induce valve fracture, surgical valve fracture. You can see the approximation of the TAVI valve between TAVI valve and surgical valve frame, and then widening of the surgical valve ring. So this is final result and a good left coronary flow. And after all procedure was done, we checked the central filter and found embolic tissue materials. And post-TAVR echo shows the significantly reduced the transaortic peak pressure and then mean pressure gradient. In the future, shortcut replace basilica, so the easier laceration of the surgical valve leaflet can be possible. So this is my summary. Patient process mismatch after valve TAVR is associated with worse clinical outcome, especially in patients with smaller surgical valve. The bioprosthetic valve fracture optimized the expansion of TAVI valve and improve hemodynamics in valve with TAVR, but also increased risk of coronary occlusion. Yeah, recent registry data showed Chinese stenting was associated with a high risk of periprosthetic risk and higher long-term CV mortality. So for an optimal valve TAVR, we have to familiar to the technique of basilica and valve fracture. Thank you for your attention.
Dr. Zhang, thank you for your great talk. So for the chimney, for the chimney stenting after the self-expanding stent, and how long of the stent would you implant it to make a chimney?
So your question is the interval between basilica and the implantation of self-expanding valve?
No, the chimney stent. If the risk of coronary, there's a compromise of, for example, left main after the core valve implantation, you make a chimney stent. So how long of the stent you put in?
How long? So usually, in my case, I prefer the 3 or the 5 millimeter outside of left main to proximal LAD. So the stent size may be more than 30 millimeter in case of chimney stent. So the stent length outside of left main to aorta is so long, so the access is impossible. I think so. I always tell my patient if myocardial infarction and any problem in LAD, so you should receive the KBJ, yeah, instead of PCI.
Okay, let us move a nice talk and us move to the next topic. Next speaker is Byung Hwang, and his talk on minimalist TAVR protocol. Mr. Hwang is a famous interventional cardiologist in Korea, and he also worked in the St. Mary Hospital show. So that's a welcome, Dr. Hwang.
Sorry, okay. I can, slide is in the monitor, but I can't see it here. So my topic is minimalist TAVR protocol. So everyone knows about the concept of minimalist TAVR. So minimalist TAVR is going toward and towards the future, and we need minimal sedation. Conventional TAVR, we have done general anesthesia. And we are doing pre-procedure workup for the minimalist TAVR. More patient selection will be very important, and being clinical and anatomical suitability for low procedure risk is very important. And as you can see in the Vancouver 3M TAVR clinical pathway, this peri-procedural approach is going toward not only in the hospital, but facilitating discharge and a criteria-driven discharge. So I think the key principles to achieve minimalist TAVR is no general anesthesia and minimally invasive procedure, all for the patient and all leads towards early and safe discharge. So first, no general anesthesia. So we are not doing TE. We watch TTE or ICE. And we usually do it in the cath lab, then the hybrid OR room. And we do it in minimal conscientious sedation. And we don't need an anesthesiologist. So I've captured our protocol in Korean. So I want to show you the real protocol in our hospital. So we do midazolam and Precedex and fentanyl, watch for 5 minutes and go on for more. And this protocol is made by our anesthesiologist consultation. And sedation is done usually in the cath room, but sometimes in the hybrid room. And sedation is done and monitored by cath room nurse, of course, under our interventional guidance. So this is our pressure loading dose. And next, minimal invasive procedure is a very important part. Conventionally, we puncture 2 femoral arteries for main body and pigtail catheter, and 1 femoral vein for temporary pacemaker, but we do only 1 femoral artery for main body and 1 radial artery for pigtail. And we do LV wire pacing, so no femoral vein puncture. And after that, puncture site bleeding control is very important. So instead of doing 2 proglides for closing main body, we do 1 proglide and 1 femoral seal. In Korea, there's no MANTA yet. So this is our picture of 5 French radial pigtail catheter and 1 femoral main device. And you can see the wire pacing needle in subcutaneous tissue. So to make no need for vein puncture. And there are some more advantages because one, less femoral arterial puncture makes a lesser possibility of bleeding and can reduce the possibility of pigtail kinking. If the distal part of the aorta is very short, very small, then after putting the main body, the second pigtail catheter can be kinking while maneuvering the pigtail. So this is the conventional temporary pacing, as you can see. But as you can see, sometimes it's difficulty in putting the temporary pacemaker up to the RV. And in the data, there is always the risk of cardiac tamponade about 1 to 2% in temporary pacing. So we've done LV wire pacing using Safari or Confida wire and using alligator clips and the pulse generator. And as you can see, wire is clipped into the positive and negative into and BP drop is also checked during the pacing. You can see a needle clipped. And another needle clipped into the Safari wire. Then after that, this is a testing of LV wire pacing. You can see it's gonna pacing is doing good, and you can see the BP drop. So we use LV wire pacing over 99%. We think in Korea, I think our center is using this LV wire pacing the most, but some centers have difficulties in using LV wire pacing. And recently, in 2023, Teleflex Watson bipolar temporary pacing guidewire has FDA clearance, so I haven't used it, but maybe this can be a very easy option to get LV wire pacing. So let's talk about post-procedural bleeding control. There is a MANTA vascular closer device, which can close up to 25 French, but it's not available in Korea. In the clinical studies, it shows excellent results. So conventionally, we use two proglides, but using two proglides sometimes makes the vessel injury with two knots concealed together, make it the vessel shrinkage in long or short periods. So we use a one proglide to make the puncture site smaller, then put the femoral seal so that the puncture site goes smaller than the femoral seal inner disc get caught into the vessel inside. Then we can put the outside disc to the vessel. So this is our real monitoring of the minimalist TAVI. As you can see, this clip ends at about in 30 minutes, but this is the patient comes into the cath room. So about preparing, about 6 minutes, we're doing the puncture. And then after puncturing, pigtail crossing the LV wire, then LV wire, pacing test, and then put the device and putting, it takes about puncture to making the valve implant about 15 to 20 minutes. And if we close, we take about 20 or 25 minutes. So in this time, first we had the sedation into the patient when the patient went into the room, but now we do not put the sedation after the puncture. We get sedation after the wire goes into the LV. So how about minimalist TAVI in special tough situations? As Dr. Kiyuk Chang showed, first, we have a TAVR with balloon valve fracture. This was a patient with left PVL after PVL closing. And this was done in general anesthesia, and you can see the TE. But after that, we have put sentinel, and as you can see, there was wasting, and we put balloon fracture, and the final was good. So after that, first BVF was under the general anesthesia, but second BVF was Minimalist TAVI was done safely. And as you can see, the case Dr. Kiyuk Chang shows, sentinel, basilica, and BVF, first case was done in general anesthesia, but we think that the procedure has been very safe, and the total procedure time was about 91 minutes. So we think that next time we can do Minimalist TAVI in this case too. So this is my take-home messages. Minimalist TAVI needs minimal conscious sedation, one femoral puncture, every wire pacing, pro-guide femoral or manta, and all leads towards patient's early and safe discharge. Same discharge after TAVI is a very important issues today, but there has to be some things yet to be considered in Korea, I think. Thank you for your attention.
So, Dr. Hwang, in your idea, every case should be the minimalist TAVR, or just some limitation you do the general anesthesia?
We almost do about over 98-90% in minimalist TAVR, and only in new like basilica or first case of BVF, some difficult cases and high-risk cases we do general anesthesia, but over about 90% we do in minimalist TAVR.
Do you have a standby anesthetist? Notice you just nurse give the sedation, and do you have any anesthetist standby for what case, or for your routine you just nurse, or you for some selected cases you have anesthetist in the room?
So making a consult to the anesthesia first, and the anesthesists are always busy doing surgeries and not helpful to our cardiologists usually. So it's very hard to make them against, I think it's very difficult. So we do not usually do it. So almost all minimalist TAVI patients have been safe, and we have not found a big problem yet.
That's great, because that's why exactly I say the anesthetists usually are really busy. If there's any emergency, you're trying to get the anesthetist into the procedure room, probably not that easy. Of course, you know, congratulations, you never had this kind of situation. At our center, they still have anesthetists trying to stand by, because it's a sort of really very real now, very real. You agree, Eric? Pretty small chance to have this kind of situation. So great. Thank you very much for your excellent talk.
Thank you.
Yeah, but no, we'll move to the next last speaker. Dr. Bapat? Oh,
yes. Good evening.
Hi, nice to meet you.
Sorry for the delay. My flight was delayed. I was just returning from TBT.
Great. You're really on time. Very nice to see you here. So you will be a last speaker in this session. So I think everybody know you across the whole world, and you're the outstanding surgeon, and also the I would say call you a structural valve interventionist. You're both titles, and everybody know you developed the very famous. Everybody use this app, Vinayak valve app. I use a lot, and I always trying to open the app to look at it before the procedure. So thank you for creating that very useful app for everybody. And I believe you will give a talk on TAVI explant. So looking.
Thank you, Jian, and I wish I was with you all, and hopefully next year. So look forward to that. I think you're right, absolutely. I think this is the next challenge we have in the field, is what we do once the TAVI fails or TAVR fails. These are my disclosures. And I think we all know that now. We know that the main difference between SAVR and TAVR is that we don't excise the leaflets, and we have a lot of stent material in the aorta. Just for demonstration, I've just shown a short profile valve. But if a valve is a tall profile, it interacts with the ascending aorta as well. We also need to understand when we excise and remove the TAVR, what design it is. And, you know, some of us who have been involved since 2000, early or late 2000, we have seen all the devices. But many times, you know, the younger generation of surgeons probably have not seen many of the older designs. So there's going to be a lot of effort from surgical societies to help people understand that different designs and how they interact. They're very important as well. And once the TAVR fails, we have only two options. This talk is going to address the surgical explant and challenges. But essentially, why we are even considering surgery is the first question. And I think we know that recent publications, and there are going to be at least 4 publications from me and my group now on feasibility of TAVR in TAVR, how many patients may have a risk of either coronary obstruction or difficulty in accessing coronaries in future. This is important because we are probably going to do TAVR in TAVR in slightly low risk patients as well. So here, this is a hypothetical paper recently published by Kendra. My group will be publishing a much larger number, slightly different. But you can see here that at least 29 to 50% may not be suitable. So if you want to explant a short profile valve, I always divide them into short and tall profile because I think the challenges may be different. A short profile valve, such as balloon expandable or Lotus, which is mechanically expandable, they interact with the annulus more. And I think the reason is they stretch the annulus and the subvalvar. There could be problems with the leaflets, such as mitral. LVOT flare can cause problem when you are trying to extract the valve. And then you are very close to the conduction tissue. And it is important when we are trying to dissect it off the subvalvar structure. This is just a short video of one of the patients. You can see, I always thought initially taking the sapien out will be really easy, but it's a really hard frame and you cannot collapse it sometimes because it's incorporated in the aortic sinus as well. So here, one of the techniques is in such case, try and bend the frame inside. And if it is really difficult, just cut the frame straight down from outflow to inflow, and then hold it with a needle holder on both sides. And here it's a chunk of a stent frame just coming out. And then here we have used a bone cutter, but we have got now a special scissor to cut this valve. And once you cut this stent frame, you can literally roll the valve on the needle holder, and it allows you a safer dissection of this valve. There are some cases where you can find a nice plane between the native leaflet, which is still there. And here you can just cut the native leaflet down to create a space as we are doing here. And then eventually slowly dissect it. Make sure you do not damage any conduction tissue. There have been cases reported where people have caused a perimembranous VSD, for example. And I have seen a case in my own center where a mitral tear happened while excising the sapien. Now, more critical part is once you remove it, examine the native leaflets properly because you still have to cut and debride them. And then, of course, do a surgical AVR. If there is an extensive damage, especially in infective endocarditis, then of course you have to do a root replacement. This is essentially what I call is the crocodile roll. This second video highlights it slightly better. With interest of time, I'm just going to forward it a bit. And you can see here, we are cutting the stent frame right in the middle. And this is not always necessary, but this is necessary in some cases which have been implanted for a very long time. And here, by just taking 2 strong forceps, you just roll the sapien, and it allows you to create a plane to cut the next part of the leaflet as we are doing here. So this is a pretty elegant technique. It's easy for surgeons who have not done a lot of these. And here again, we are going outside the native leaflet to create a space to take it out like a barrel of tissue and remove. And of course, the next steps are doing a surgical AVR as we all normally do. For acute explant, it's relatively easy. But why I show this picture is because it has happened again in my center that the valve was expanded. There was a problem with a tear. And then when the surgeon just thought he was not involved in TAVR, he just tried to pull the valve out and it caused more damage to the aorta. So I always tell people that bend it inside and then remove this valve. And it's pretty strong device. So especially in case of Sapien and Lotus, this is going to be very important. Now, some of us have probably forgotten this valve. This was called a direct flow. And you can see, just for those who have not seen it, this is a valve we used to implant in the LV, unfurl it. It had two rings, and then we used to pull it up. And once you are sure that your position is correct, there is no paravalvular leak, then you fill those two rings with polymer. And that was the idea. It worked quite well. It was the time when we didn't have CT analysis that well, but those polymers can become really hard. And I want to show you a case. You can see this is how the valve will look like when it comes back. This is the case which came back 6 to 7 years later. And this is exactly how it's going to look like under surgical view. And you can imagine how hard it is going to be for a surgeon to explant this valve. This valve literally has to be removed piecemeal. And this is the way, this valve was removed. And AVR was done with a root enlargement. So these patients are going to be extremely challenging when they come back because they're not usually suitable for TAVR and TAVR because of, I can go back to the picture. I think you all will agree that there's a lot of loss of true internal diameter, and surgical explant is going to be the only option in these patients. Now, what about tall devices? Tall devices definitely engage with ascending aorta. The funny part of this is all the tall devices are made of nitinol, and nitinol is very flexible, especially when you open, you can put some ice slush to make it more pliable. But it is also important to dissect it very slowly and clearly from the ascending aorta. So I'm going to show you planning, which is very critical. As you can see, that tall devices can come into our cross clamp area. This is where we could cannulate this patient. This is where we could put a cross clamp. And then incision, I used to take an incision above the valve. Now I have changed my strategy. I take a hockey stick incision on the valve, and that actually allows me to dissect the valve better from the ascending aorta as well as below. This is one of my senior residents. He's removing the evolute R. The reason I show this video is to highlight that before you start explanting it, examine the valve properly, identify where the left main and the right is, because if you don't have retrograde coronary cardioplegia, you may have to use it. We always open the leaflets and see how deep the valve is, which tells me whether it's very near the mitral valve. Am I going to interact with the mitral valve when I try to explant it? So this is exactly what Ben is doing. And once you do that, you start dissecting the top of the device very slowly. Again, he was my chief resident, a bit impatient. So he's trying to dissect it with scissor. And this is exactly when people damage the ascending aorta and they have to do ascending replacement. So instead of that, what we use now, if we use the endarterectomy spatula, and that spatula actually helps to create a nice plane. Sometimes it's hard. You just have to be patient. The last explant I've done, which was around 5 years or 6 years later, it's one of the hardest explant I've done because it was really stuck to the aorta, but we didn't have to do ascending replacement. Again, meticulous and slow patient dissection of this valve is important. And you can see how pliable the nitinol is. And I think that's an advantage of nitinol devices. They interact with the aorta, but at the same time, they're easier to explant from the annular portion. And after dissecting out slowly from the top, as you can see here very nicely, now the valve comes out. And now what we do is we push the valve inside from the lumen and not dissect outside. So he is going to push this stent inside in the lumen, and you can see how nicely it bends, and then it clears and this has worked very nicely through and through. even for valves which are there for 7 years and 6 years. So this is a good technique to remove the valve. And once you go circumferentially, then of course you can cut the native leaflets and do an aortic valve replacement. Next video is slightly 5 years later, infected endocarditis, which was healed. This is a patient we did a live case for TCT, and you can see endocarditis, which has healed completely now. Here, the ascending part and of the aorta, and because the ascending aorta is a bit dilated, this was a bicuspid valve. Now you can see that there is not much interaction with the evolutar and the ascending aorta. So here again, we are using the similar technique to remove this valve, nothing different. Again, using the spatula for a very patient dissection, I would say, and then remove this device slowly, making sure that we don't damage the mitral and the conduction tissue. Sorry. So what are the real world results? The techniques are, of course, we are making an effort to teach a lot of surgeons. And in my center, for example, I have scrubbed with every new surgeon to help them TAVR explant. So our aim is to keep the mortality low. And can the mortality be same as the isolated AVR? So we collected, there are 2 registries which we are running at present, and one of the registries is Explant TAVR. There are 38 centers with 223 patients. You can see that this is an international collaborative registry between all the friends we know. The mean age of the patient was 72 plus to minus 10 years. And you can see that the STS risk score, although seemed, intermediate in some, definitely low risk were only 28%. We could find reliably that only 20% of patients were not suitable for TAV in TAV, but my suspicion is the number was much larger. I wouldn't pay attention that much to the surgical explant time because some of them were infected endocarditis. This is a very early experience, so you can see that around 40% were endocarditis, 23% were structural valve deterioration, 15.9 or 16% had significant PV leak as well. Some patients, interestingly, were referred back because of PPM, and we had to do a root enlargement or a replacement for that particular indication, not to no indication because there was a damage to the root. Not surprising, this is the early cohort. So these are the patients who had TAVR because they were intermediate or high risk, and 40% presenting with endocarditis. The outcome at 3 years, you can see that only 73.3% survival. But this is now improving, and centers like Michigan and centers like ours are collaborating, large number of cases now to highlight that the mortality is now much lower than this initial mortality. So I think we also have to address this main question is if we have TAV in TAV and TAVR explant as the only option, how do we figure out which patient, low-risk patient should have TAVR? And I think I'm not going to address this question in this talk, but I think we are going to come back to this again. TAVR devices also have to modify their design maybe in future. Like, SAVR devices, you can expand them now. We have got techniques such as basilica, double basilica, and maybe in future, better techniques to do the basilica quickly or remove the leaflets are going to be very, very important. So to conclude, I think heart team discussion when you have a TAVR failure is important. We always decide based on life expectancy, based on complication risk, which is mainly coronary obstruction, and based on other surgeries, such as some TAVRs have been explanted because now there is a mitral disease with it. We decide, should we proceed with TAV in TAV or TAVR explant? The main risks for TAV in TAV are coronary obstruction, PPM, of course, and leaflet overhang. While TAVR explant, the main challenges are injuries to the surrounding structure and a need for a more complex operation in a high-risk patient. So I think the technical tips in these talks would be respect the anatomy, use the CT scan, and important to spend 10 to 15 minutes to explant the valve so that we don't make a simple operation into a more complex operation. And majority of the cases, you will be successful in doing a AVR and only if needed, root replacement. And finally, I would like to say that hopefully before TCT, we will be also releasing the TAV in TAV app. And it's an app which is going to help all the centers in the world to go systematically and plan and use that app with a CT software to decide, should you do a TAV in TAV or should you refer this patient for surgery? Thank you.
Vinnie, thank you very much for your excellent talk as usual. And because of time, I will only have one question. Okay, and okay, go ahead with your two questions.
Thank you so much, Vinnie. This is Eric Finkelstein. We miss you here. Anyhow, I have a question. You know, we're repeating again and again the term of patient-tailored therapy, all right? Now, there are so many reasons for TAVR failure. And I think that the main reason for doing an explant is the impossible to do a TAVR in TAVR, mainly for coronary obstruction, PPM, etc. But there is definitely a group of patients, which is, I think, not a small amount of them, that I could think of kind of an hybrid procedure. Instead of making you work like crazy on explanting all the struts, why couldn't you do a hybrid procedure in which you are taking just the leaflet or the valve inside and then put in there, I'll help you, to do a TAVR in TAVR within the operating room?
No, absolutely. And I think that there is a registry, parallel registry, which is running now. We have just started it. And this is really critical. And I really like your question, because there are patients who are very high risk. And the last thing I want to do is extend the bypass time and make it into a horrendous operation. So these are the cases where you just excise the leaflets and sometimes even cut part of the stent post if it is in front of the coronary, which is important, as you know, for some structures like, say, core valve or evolutar, and then deploy a sapien under vision. And this has been now done very well. Today, Keith Allen actually presented their own experience of 6 cases, very high risk cohort, and with really good 30-day outcome. So absolutely, I think that's something which is going to be included and should be a part of what we do. Thank you.
Thank you.
Actually, it's the same question as Eric about how to refine the surplus technique. Did you think it's necessary to add additional surgical stitch to anchor the TAVI device in the previous TAVR frame? Is it necessary or?
No, it's not necessary. The stent really interacts beautifully with each other. And, you know, we have experience now, not just in TAVR in TAV, open TAV, but as you know, Percival valve, which is a sutureless valve, which is essentially like a TAVR device. And it's really important that to understand that as well, that when the stents interact, they give more stability. But at the same time, you can't manipulate it that much. So precision is going to be important.
Okay, did you use the connet in the high frame explanation? Connet, I mean, did you know the connet?
Connet, you use a connet?
Connet,
yeah.
Right. If this is a TAVR explant, so you know there is no suture or anything. You just take it out and do a replacement. I would like to add one more technique. Sometimes in a very high risk patient, if the top of the frame is stuck to the aorta, you cut the aorta with the stent frame. You know, we and leave it behind. Just take out the lower part of the evolutar or taller device, and then leave that stent behind. It's incorporated nicely in the aorta. It doesn't really matter. We do that in dissections, right? So we know that this is not going to be an issue. So I think it's critical that, as rightly said, you don't have to really go after every case to explant it. But in a younger patient, I would try to do as detailed, slow explant as possible. If it takes 20 minutes, it's worth it. But if I know that this is an elderly patient, I'm just going to cut the stent frame, remove the lower part, and then do a AVR or deploy a TAVR device under vision.
Thank you, Vinnie. I'm pretty sure there are lots of questions for this, but due to the time constraint, I think we have to move to the next session. Thank you very much. Thanks, everybody, for your participating.
After the enthusiastic discussion, let's proceed to the last session, a roundtable discussion on alternative access for TAVR. Please welcome our renowned moderators and participating experts. Thank you.
Okay, let's get started. You're the first speaker. Okay, let's get started. The last session of this meeting. And we have a roundtable discussion regarding the alternative axis for TAVR. I think although we use less and less alternative axis, but I think still have some trouble cases we need to use this kind of axis. So first of all, I would like to invite Dr.Arik Finkelstein to give us an overview on this topic, please.
It's working. This is not an overview, and I was not supposed to create a lecture, but I don't want to be a fun spoiler for the next speakers. But the question is whether and how much do we need them? Because we all know the alternative access that you're going to speak about. And I'm not going to go into it. What I want to say is before your lectures is two things. One is that in a center like our center, for instance, well, I was doing in 2022 around 300 TAVR cases, of which only 2 could not go into 14 French sheath. And I had to decide which alternative access. And in my vision, the first choice of alternative access is a transaxillary or transubclavian, of which we're doing those days even without general anesthesia, but just with 2 proglides closing just like a transfemoral. All right, with the protection of a balloon, etc. I let the other people to explain exactly. All the rest alternatives, which namely is Transcaval, I'm not talking about or Transcarotid, I'm not talking about direct aortic or transapical, which are surgical alternative options. But if we're talking about Transcaval or Transcarotid, I think that in a country like Israel, for instance, and maybe even in countries like Taiwan or even Korea, in which I think that the TAVR volume is not bigger than Israel, I think that there should be, and that's what I advocated as the president of the Israel Society of Interventional Cardiology, there will be one center doing Transcaval, one center doing Transcarotid, because none of us is going to learn and be an expert in Transcaval if you're doing it once or twice a year. None of us is going to be expert in Transcarotic if you're doing it once a year. So I think that transsubclavian or transaxillary is just very, very similar to transfemoral. Anyone can do it. It's just a very short learning curve. And you got to have a backup of a vascular surgeon. But all the rest, alternative access, should be concentrated in one center for a country like us. Leave the ego aside and just let somebody be an expert of those very few cases that we're going to need. And I'm telling you very few cases because you heard a few minutes ago Eberhard Grube gave a talk about TAVR, his life view, and he told us about the first implantation that we were doing in Israel last week, Ran Kornowski and me, of this valve that is built of two pieces that are going in and are rebuilt within the body. And that's why it's not working. I don't know why, but it's very, very easy to implant. Everything is almost automatic. And the size of this is 12 French. This is as compared to the Evolute R or Evolute Pro, to the Accurate, to the Sapien, and this is 12 French outer, true 12 French today, and pretty soon it's going to be 9 French. So good luck with your presentation of alternative access, but as I said, it's going to be more and more rare and needless and should be concentrated in only one center for a country. So this is what it's going to be in the very, very near future. Thank you so much for your attention and good luck with your presentation.
Well, I think we can close the session. In the future, I think miniaturize of the devices or the delivery system will be the way to go. But we are still have a real world needs of alternative access, no matter in which country. So first case will be presented by Dr. Philip Adamson from New Zealand. That will be a Transcaval case, please.
Thank you for the invitation to present. Will my slides be shown? Can you see my slides?
Not yet. Please, yes.
So yeah, as I say, thank you for the invitation to present. This is an example of a Transcaval case done here in New Zealand, where we still have occasional patients, unfortunately, who require alternative access for TAVI. Less than 5%, but we do still have patients. Because I've only got 5 minutes to talk, I'll just really limit the talk to what I think are the key points that are relevant to Transcaval TAVI as opposed to other alternative access approaches. And the case in discussion today was a 63-year-old woman who was referred to us with symptomatic severe aortic stenosis. And she had a history of severe peripheral vascular disease. She'd had recurrent strokes and had bilateral carotid stenoses, so we didn't consider her suitable for a carotid approach. She had a number of other important comorbidities. And in this situation, Transcaval is our preferred option. Here you can see the image on the right is the CT scan of her planning CT showing what I hope you'll agree is severe diffuse stenoses of both iliac arteries, which really made it impossible for us to go via the femoral arteries. Can we advance the slide? Go back one. So as with most structural interventions these days, the planning, the CT plays a vital role in the planning. And the sorts of things that we're looking for on the CT, we need to identify a window that's free of calcium. in the aorta, and it's got to be sufficiently far away from the bifurcation, the distal abdominal aortic bifurcation, and the renal arteries, so that if we do need to use a bailout covered stent, that's an option. We need to make sure that there's no other structures in between the IVC and the aorta at the puncture site, for example, loops of bowel. And we also need to identify the anatomical height in relation to the vertebral bodies, because it's the vertebral bodies that we can see fluoroscopically and that we use as our landmarks. So once we've found a suitable location, we also want to identify the estimated fluoroscopic C-arm angles that will be perpendicular to the puncture, so perpendicular to the line between the IVC and the aorta, and en face to that puncture site as well. And the two middle figures that you can see on this slide show those images. At the top, we have the perpendicular view, which shows our angled guide catheter with a stiff coronary wire in it. That's placed in the IVC and is pointing towards a gooseneck snare sitting in the abdominal aorta. The figure beneath that shows us the en face view, which we use to confirm that we're pointing towards the center of the snare. Then it's a relatively simple case, once we're pointing in the right location, of attaching a diathermy pencil to the external end of the coronary wire, and just a second or two of gentle forward pressure with the diathermy on, and you can see the wire traverses very straightforwardly from the IVC into the aorta. From here, we can snare the wire and advance it up the aorta, and with a succession of microcatheters can exchange this 0.14-inch wire for a 0.035-inch stiff wire. And over that stiff wire, we can advance the delivery sheath for the TAVI device, in this case, Edwards E-sheath. And you can see on the figure, on the image, the moving image on the far right of this slide, that it traverses across from the IVC. There's a slight moment of resistance as it enters the aorta, but it passes relatively straightforwardly. So from here, we go on and proceed with the TAVI as we would normally for any other TAVI. And can we advance to the next slide? So at the end, we need to close the hole, and this is again the difference from a traditional transfemoral approach. We favor just using a duct occluder, which is an occluder with a single disc, because we want to form closure of the aorta, but not closure of the IVC, so that if there is residual shunting, it can drain off into the IVC. And that's what you see here with the duct occluder deployed. There is still residual shunt, and we expect that. We typically see that, and it isn't of any clinical significance. The important point is that there is no bleeding into the retroperitoneal space. There's no dye holdup in the space. Everything is going across into the IVC and returning to the circulation. And the figure you can see in the top right-hand corner of the slide is a published figure from a case series of 100 cases of Transcaval, showing that the majority of people have residual shunt at the completion of the case, but this isn't of clinical significance, and the vast majority of people subsequently go on to completely occlude at the puncture site. And the figure beneath that, the CT scan, that is actually from this example case, and it was done one day after the TAVI. And again, it shows complete occlusion with no residual contrast into the IVC. So essentially, the device that we deploy acts as a scaffold for thrombus formation and later endothelialization, rather than acutely having to occlude the defect completely. So hopefully this has highlighted some of the important points that we think is a reasonable alternative access approach for TAVI.
Okay, well, excellent talk and the case. I think although it seems to be difficult, but I think every procedure or details are rational, I think. Thank you. And the next case will be delivered by Dr. Yung-Tsai from Jian General Hospital. our center, the usual alternative access would be the transcarotic. Dr. Lee, please.
Yeah, this day already is 83rd. He was under hemodialysis, so that we can see here the iliofemoral artery and include the descending aorta was calcified, and the smallest lumen is around 3 to 4 millimeter. So we decided to do the transcarotic. Carotid artery is superficial, so we use the no-neck incision. If the patient did not stroke, so the quality of the carotid usually very well, and just a small incision here. That's quite easier, and we just spray the vein away so that we can see the carotid quite well. And takes some minutes to do the stitch over there, and you can feel the quality, and you can check the backflow pressure and see we need a bypass. And at the same time, we can implant the brain protection device to this area. So everything just like the Transcaval one, because we have grabbed. We anastomosis grabbed to 2 layers, so that's it just very similar to femoral one for apparatus. And however, it's need the general anesthesia for the showing the carotid artery. So that we have done the 20 cases without stroke, and I think it's very easier way to use the carotid, because the carotid artery usually larger than 6 millimeter, and every device can cross that.
Okay, thank you.
I just want to understand. Your first alternative access to TAVR, in the case that there is no transfemoral, is transcarotid.
It's in our center, we do not do the minimalist, except the patient asks. So the 95% is general anesthesia, and because in previous experience, the transaxillary, I think in Taiwanese, the axillary artery is around 5.5 to 6, and the axillary, and really? Some calcification, especially patient receive hemodialysis. So that we choose the carotid first before we use the apical, aortic, and any other where. However, the carotid artery is quite healthy, so that's after that we use the carotid artery.
Okay, thank you.
Okay, next talk will be delivered by Dr. Chanapong. He's going to tell us how to manage vascular complication in case of this kind of complication just happened.
Hi, good morning.
Morning.
Yes, good morning from Bangkok. Thank you for the opportunity. Can you see my slide?
Not yet.
Hello?
Hello? We still cannot see your slide.
I'm sorry.
Okay. Coming up. Please show the full screen mode.
Yeah. Is it okay?
Okay, please go ahead.
Okay. So on behalf of the TAVI team from King Chulalongkorn Memorial Hospital, Bangkok, Thailand. So I am their cardiac surgeon who do their TAVI, including surgical AVR as well. So today my topic is about how to handle with a vascular complication. So as we all know from the Valve Academy Research Consortium, number 3, the VAS3. So the vascular complication can define as the major vascular complications, such as anything that involve to the main aorta, such as the aortic dissection or even the aortic ruptures, or any vascular injury that can resulting in death or permanent damage of the patient, distal embolization, or the unplanned vascular or surgical interventions that can cause death or the VAS type more than 2, the bleeding, irreversible ischemia, or permanent damage. And the VAS type 2 bleeding is defined as when we need to transfuse the patient more than 2 units of blood, or the dropping of the hemoglobin more than 3 is about 3 to 5 grams per deciliter. So from the literature review from the STS and ACC TVT registry, the vascular complication is a little bit high on the early ELA. It's about 15 to 20%. The vascular complication or the in-hospital bleeding. But the trend is going down to just below 10 from the big cohort from the registry of TVT. So in general, incidence of the vascular complication right now is about 9.3%. And the in-hospital bleeding is about 7.6%. The factor associated with the vascular complication, including the female sex, as we know that the vascular tree is a little bit on the smaller size, or the patient who need the bigger valve that eventually need the big sheet, more than 17 French, or the patient who has the history of peripheral vascular disease, and the patient who has a little bit bigger BMI, that those are the factors that associate with the vascular complication. Why the vascular complication is so important? Because that vascular complication, including the bleeding event, translate into the all-cause mortality and also the hospital readmissions, including in the short term, it means 30 days, or even the intermediate term as the 1 year. So basically, the aortic dissection or the rupture, which we define as a major vascular complication. The incidence is not that much, it's below than 2%. It can cause by the catheter, or even it can cause by the device itself, such as post-balloon dilatation a little bit too much, or if the patient has their unhealthy tissue, the severe calcification at the root. Even the incidence is not that high, but the mortality after the aortic dissection in TAVR is pretty bad. It's more than 50%. Other complication that we define as sometimes minor complications. The most common one is the iliofemoral dissection or even the ruptures. The incidence of the dissection of the common femoral artery or the iliac artery is about 2 to 20% if we do the percutaneous approach. But it's a little bit lower if we do the surgical cut down, because that is we will prepare for the bleeding side, and in the selected case, the incidence is lower, it's about 2 to 7%. And the fatal iliofemoral ruptures, the incidence is not that much, it's about 0.0% to about 9%. The most common site that the iliac rupture is the external iliac artery. It can happen in any phases of the procedure, the sheet up or sheet down, or at the beginning or the end of the procedure. But luckily, most of the iliofemoral dissection or ruptures can manage endovascularly. Angioplasty with the prolonged balloon inflation may be sufficient for the intimal medially appositions. But in some cases, the extensive dissection may require the stent implantation, or if failure for the endovascular in some patients eventually may need the surgical repair. One of the complications is the access site pseudoaneurysm. The PSA is about 2 to 5% in the TAVR case. Basically, it is the contained ruptures of the external with the external vascular bleeding into the pseudocapsules. Spontaneous thrombosis is common if the pseudoaneurysm is small, usually smaller than 3 centimeters in the patient who doesn't need anticoagulation. But in some patients, if the pseudoaneurysm is large, that can cause symptoms such as discomfort, local infection, or the septic, or even the ruptures. That patient we need to address and treat it. With the successful rate of 97%, with the ultrasound guide thrombin injection is a favorite choice of the treatment of this patient. But if the pseudoaneurysm is pretty big or cannot treat properly with the thrombin injection, the surgical repair is the option. So basically, if the patient has the aortic complications such as the rupture or dissection, open surgical repair is the option that patient has. But if the patient has the iliofemoral complications such as dissection or perforation, we can treat the patient with the endovascular treatment with the high successful rate. So I want to show our result in treating of the vascular complication. We start about the TAVI program right now is about 13 years. We did about 259 cases. 89% are transfemoral, and only about 10% is alternative accesses. Direct aortic is about 5%. Transapical is 2%. It happened at the first ELA of the TAVI program. And transsubclavian is about 2.7%. Our strategy for the alternative access is we decide to do the TF first, and then transsubclavian, and then transaortic, and the transapical is the last choice. Our patient has 25% of the vascular complications, is about 9.6%. In the 25 patients, 24 patients is 96% are transfemoral approach, and 1 from the transapical approach. Luckily, we don't have the vascular complication in transsubclavian and direct aortic because all the cases are open cut down. So we meticulously choose and close the incision with the surgical technique. If we separate the complication into the device type, most of the cases are self-expandables. We use a core valve or evolute, and we also have the Hydra valve and accurate neo. But if we look at by the numbers, the balloon expandable valve pretty has the lowest complication of the vascular intervention in our cohort. Cell expandable is pretty the same, a little bit higher side from the accurate is about 15%. If we look deep into the vascular complication, the major complication that we have the 16%, 3 are diaortic dissection and 1 from IMH. And the minor complication, 84%. The most common is iliofemoral occlusion, following 28% followed by the iliofemoral dissection, 1 pseudoaneurysm, and the access site hematoma. In all 4 cases with their major vascular complications, we have 50% mortality. So one go to the ER and death after operation. One death is delayed diagnosis. The patient doing fine after the operation, and then cardiac arrest at the ICU about 3 hours later. Basically, the patient cannot survive the CPR. And 2 cases are survived after the conservative treatment because the patient has really fragile and higher elder. So we discussed the risk and prognosis with the family. So the patient opted the surgery, but luckily for them, they are both survived. And about the minor vascular complication, most of the cases, 5 cases, we can do just a balloon angiogram. 9 cases, we have to put the stent. And we have 3 cases which they are failed endovascular treatment. Eventually, we have to open repair the iliofemoral vessel for 3 cases. And 1 percutaneous balloon with the cover stent in the pseudoaneurysm case. This patient has a big pseudoaneurysm and failed the ultrasound compressions. And the 3 cases with the hematoma just respond well with the manual compressions. And 3 cases that we did the open surgical repair because the patient, all 3 cases that failed their endovascular treatment because of the vessel injury is really, really big. Most of the case we have to do with the patch repair, and we have to do the some kind of balloon angioplasty at the repair site. So this is our experience with the vascular access complication and management. Thank you for your attention.
Okay, thank you very much. I think we'll just start the discussion, and so stay online, and I'll ask the panelists for questions from the beginning, from the beautiful talk of Philip regarding the Transcaval, which I got to tell you, Philip, I'm truly envy because, no, I'm serious, because I took a decision, as I said in my introduction, that I don't think that every center should do Transcaval, but we should build a center of excellence for each procedure. So just in order to show a goodwill, I said my center, which is the biggest TAVR center is Israel, we're not going to do Transcaval. I let somebody else do it. So I'm truly jealous. Do you have any questions regarding Transcaval?
Okay, Philip, I'm Casey Lee, a cardiac surgeon from Jeng General Hospital. So my first question is about the fusion technique or the combined CT in the hybrid OR. Which one you prefer, or you adapt both techniques for the image, more accurate image information for the Transcaval technique?
Sorry, are you asking whether we do this in a hybrid operating room or the cath lab?
Oh yeah, I mean, did you think the fusion image fusion technique?
No, we don't. Yeah, so it's a good question, and Arik, I suspect New Zealand probably has a similar population size to Israel. I don't know the population of Israel, but we're about 5.5 million, and
we are close to 10.
You're bigger than us, but yes, I support your idea of having centers of excellence. You know, we're a smaller country, and all the TAVI operators in New Zealand know each other, so we do have some sharing of cases around the country. In terms of the question about imaging, no, we don't use fusion imaging in the cath lab. The CT we use, we look very carefully at in the planning phase, but actually you can get all the information you need to guide the procedure just using fluoroscopy, because we have the height of the puncture, which is dependent on the vertebral bodies. We just count up the vertebral bodies. And we know, for example, if we're aiming for the middle of the third lumbar vertebra or the disc in between the second and the third vertebra, that's the height we're going for. And then in terms of the angles, as I say, we get the planning angles from CT and we make sure that we're pointing both at the center of the gooseneck snare, both vertically and also in the on-fast view.
So before you release the occluder, when you do the aortogram, there is some extravasation from the aorta. Would you still release the occluder, or what's the next step you adapt?
Yeah, so it's there is a shunt, but it's not extravasation. It's not leaking out of the vascular structures and remaining in the retroperitoneal space. It's shunting across from the aorta to the IVC. And indeed, you know, you can take your time doing this. There's no rush. When you pull the sheath back and you leave a large hole in the aorta and the IVC, the patient remains very stable through this.
I mean, if they still have some extravasation from the aorta, I mean, before you release the occluder, what's the next step you will adapt?
So if there's a concern, then you have an option of taking a balloon in the aorta and ballooning the device, because usually if you don't feel that you've sufficiently reduced the shunt, it's because the device is sitting at an angle. And if you balloon it in the aorta, you can push it out so it's now perpendicular to the wall of the aorta.
According to the experience of EVA or TIVA, the balloon maybe need 20 or 12 French sheaths or 14 French sheaths. Patients have the problem of femoral access. What if you cannot put the 12 sheaths? What's the next step for stop the extravasation?
Yeah, so you've highlighted the exact weakness of some of the approaches. We've found that we can get lower profile balloons, so we can get a 9 French balloon, which is usually large enough for the aorta. But it is an issue if you need to put a covered stent in. We haven't needed a covered stent thus far, fortunately, because I agree. I suspect there would be difficulty in delivering a covered stent.
So that's my little comment about maybe we should have a less bailout procedure. I mean, the Transcarotic.
Yeah, we haven't required one thus far.
Philip, as far as I remember, in the first days of Transcaval, I remember I went to meet Alan Greenbaum, who tried to teach me how to do that. And the hypothesis was that since the pressure in the inferior vena cava is always precedes the one in the abdomen, you don't need to do any occluder, because there is not going to be a spillage of blood into the abdomen, but rather it's going to be sucked into the inferior vena cava. That's right. But in spite of that, a long time you decided to put this occluder. Am I right?
Yeah, that's right. The reason for that is to prevent having a large residual shunt. I think if we left a large residual shunt, patients would get high output heart failure. So the point of the occluder is, as you say, not to completely occlude the aorta and stop any bleeding, because bleeding is not an issue because it drains into the IVC. The purpose of the occluder is to reduce the size of the shunt so that the patient isn't left with a large shunt.
Makes sense. Thank you. Yeah. Okay, regarding the transcarotid, I can't argue with the fact that you're doing it and you're doing it beautifully, but somehow intuitively, I feel so in such an uncomfort to think that I'm dealing with the carotid instead of the subclavian regarding stroke, etc. I swear to God, it's nothing logic, it's more like intuitive, that I feel very uncomfort to deal with this huge device still in the carotid artery. and so many times.
Yeah, it's always a concern. However, we are a cardiovascular surgeon, so that we all know the innominal artery, carotid artery always exceed 6 to 7 millimeters, so it's quite large. And in the lower part, the quality is usually fine. In some cases, only some eccentric lesion. However, the lumen is large, so you can do in the cast well. And we use a graft to connect to the carotid artery, so you do not need push the sheath into the artery. You just protect the device into the aorta, and you pull back the sheath. It's just like the sheathless device. That's just very small cast into there. If you are worried about the stroke rate, and sometimes we use the shunt, and another way you can put in a Boston filter wire to the distal carotid artery, prevent thrombosis.
Yeah, thank you. I got to comment regarding the transfemoral, okay? You know, we are doing as a routine, and I don't give up a single case of a safety 0.014 wire, either Ironman, okay, or a Grand Slam or whatever. I don't give up a single case that will remain a safety wire until the end of the procedure. Now, we are using almost those days exclusively the Manta, which is truly amazing. I think that the ProGlide is very good as well, but the Manta is a game changer with patient selection, of course. And in those cases that there is a problem, I want you to try it, okay? You just inflate 7 millimeter. We have a monorail balloons, just like a PCI balloons of 6, 7, or 8 that are compatible within 6 French guiding catheter. And this is the same guiding catheter that you start the procedure, right? Now, over this 0.014 wire, we put, if the closure device is not acting correctly, we put, according to the artery, a 7 millimeter or 8 millimeter balloon inflation. I pull the wire so it won't be along the leg, but just up to the end of the balloon, because you give protamine, and I inflate it by the watch for 20 minutes. I swear to God that unless you just took the artery and tore it to pieces, the 20 minutes inflation with a balloon and the inversion of anticoagulation, there is no bleeding. I swear to God that so far, I don't really know how to do alone a covered stent, because I have done it only 3 or 4 times in my entire career of 13 years of TAVR, or 14 years now, all right? Because this long inflation with a balloon is just solving everything almost. And one more thing, and those arteries that looks a little bit smaller, I find it much easier to treat it with a shock wave in these places where it's smaller and go still transfemoral than going for alternative. So I don't exclude the alternative access. It's good, it's relevant, it's, as I said, I'm envy, but I think that until proven otherwise, the first choice should be transfemoral, because this leaves you with what we heard before, the minimalistic approach of TAVI, which became so important.
So Eric, may I ask a question about the transfemoral? If the patient has borderline iliac access, so when you put the sheath, But if you complete the procedure, you cannot retrieve the sheath. What's the next step you will adapt?
What do you mean you cannot retrieve the sheath?
Sometimes I ever heard some patient, when some surgeon have the problem and the sheath is very tight with the femur artery or iliac artery. So when they try to sprint or some maneuver to retrieve the sheath, they have the disaster to sever the artery.
I'll tell you the truth. First of all, if the patient is with a peripheral artery problems and his minimal diameter is like, let's say, 5 millimeters, okay? My default valve is not gonna be Edwards, definitely not the others, but rather the Evolute Pro Plus or the Evolute FX those days, which is profile is definitely less, and in which you can push until the narrowing with the so-called sheathless, and then go on with the valve itself. So you don't cross this narrow part with the sheath, so you don't have to pull the sheath back. You understand what I mean? But I understand your question because I had one case in which the sheath was stuck and I need the help of a vascular surgeon. But that was just in one case. Otherwise, look, you have experience, you know when you push too hard, and if you push too hard, you know, you have the consequences.
So how your vascular surgeon deal with the problem?
We took the patient to the surgery room. Yeah, but it was one case only, and it was because the operator was not gentle enough. But if you are not really violent, you cannot push the sheath in a way that you want to be able to take it out. It's a rule in life. What can go in can go out.
So your suggestion is the best treatment is prevent, but not do it.
Definitely. I showed it in my previous lecture of complications.
So how about Chanapong's opinion? Because you are a cardiac surgeon also. What's your opinion about the sheath stuck on, in the iliac artery or femur artery? What's the next step you will adapt?
So I think the prevention first is the prevention patient selection is the most important. If we sit in that situation, the first thing that I have to make sure that the Y is still in, and I will access the contralateral to put maybe possible the occluder balloon at the distal aorta. And maybe we have to decide that we have to pull it out or directly to the OR. So make sure that we have the protection by the aortic occlusion from the other side.
My bailout procedure may be, yes, contralateral to send a body wire into the large sheath. Let me try to manipulate the sheath out. But you are right, you can put so that's why we maybe need another large sheath on the contralateral side to put the balloon above the lesion side, and put the body wire across the ipsilateral sheath. Then we retrieve the sheath. So maybe we have the problem to tear or the injury the artery. So just tell the anesthesiologist to take care about the hemorrhagic shock. Yeah. So how about Philip? Is there any comment about the problem, Philip?
No, I've not actually come across that problem of not being able to remove a sheath. We routinely sort of cross over with a rim catheter so that we can take images when we remove the big sheath, make sure there's no disruption of the iliac and that we've got appropriate closure, and then we're ready to cross over with a wire and a balloon if we need to occlude. But I've not encountered the case of not being able to extract the sheath.
Okay, we have a very interactive session, and the session is come to the end, and also the meeting. So I would like to thank all the participating experts to this session, and the moderator Eric, and the discussant. Thank you very much for your attention.
Ladies and gentlemen, as we approach the conclusion of the Taipei Valve Summit 2023, we extend our gratitude to you for contributing the success. Now, with great anticipation, let's welcome our esteemed Professor Jeng Wei and Professor Jian Ye, and they will deliver the closing remarks. Thanks again for your active participation.
I saw that Professor Wei should give a closing remark. Not me, but anyway. So, dear Professor Wei, Professor Yin, and Professor Finkelstein, I hope I remember your last, and all the international, speakers, speakers, faculties, and also the local speakers, the faculties, and the ladies and gentlemen. So, as you know, we now complete our 3 days of outstanding program. And this program covering almost every topic, almost all the major topics and hot topics on all the transcatheter therapy for multiple valve disease, including aortic, mitral, tricuspid. It's all topic we have covered. So we have a fantastic speakers from all over the world and more than 30 countries this year. So impressive, and I think all the speakers are all the experts in this area. They give excellent summaries and the lectures and advices and the future perspective. Which was very, very helpful for everybody. And honestly, I learned so much over the past 3 days. And as I said, this 3 days probably I don't need to study for a whole year now, because I learned everything, even for the futures. That's great. And of course, this year's also we have a discussed session. This was really, really stimulating, and generated lots of helpful and thoughtful discussion, and also will help us in our practice. Particularly, we're doing procedures. We know, we just had a lecture about the complications. I think that's very critical, because we're doing the case. We really want to learn from our masters. They really give lots of tips and advices how to avoid the complications, how to achieve best outcomes and best care to our patient. So I think the whole program is fantastic. But without the local organizer committee and the Professor Lee or the Professor Ying's hard working, I'm pretty sure they put I don't know how much hours, about the endless count of the hours to prepare this very stimulating program and the organization, and also for all the hospitality. I think that's what I really want to thanks to all the people's work on this to organize this meeting. And also, I really want to thanks to the Professor Ying's whole team, staff for their hard working, and they are actually behind the scenes. And you know how much the time they put it. They organize the committee and they make sure that everything program is so smoothly, over the 3 days. I'm really impressed with your team. I just talked to them. I say, and not really many places you can have a whole team to help for this kind of a 3-day summit, and also in the 2 days weekend, and it's not easy. In that sense, no way you can have this whole team to help on this kind of meeting and program. So I'm so impressed with the organization, and also actually Zhengxin Hospital is a really like a how to say, it's a sample of the collaboration between the cardiology, cardiosurgeon. They are probably one of the best. It's not best, but probably almost best the team in the world I ever seen, because they are so collaboration. They are so like a good collaboration, even in like cases, operations that you can see during the live case or the live case, surgeons, cardiologists work together. It's really example of the heart team. I think that's really we should learn from this kind of excellent team, and how they work together. So I think it's a great example for everybody. And lastly, I think I also like thanks to all the people, camera and the computer. This kind of they work hard to make this program went so smoothly. And thanks again to everybody, and also thanks to everybody for participating and take your time to participate in discussion and all the other things. We really appreciate it, and I hope we can see everybody either online, or we probably will hybrid again, I guess, online or in person next year. And I'm pretty sure next year we'll have more stuff, and will be more exciting programs. So hopefully to see everyone next year. Thanks again. I think we are, Professor Wei, you want to give some last final close remarks?
Well, I'd like to thank everybody coming for this meeting, and especially the faculties and the other organizing committee, and also especially for the participants. So thank you again, and wish you every happiness and success in your career. Thank you.